Today I'm going to present to you a study called IMPRESS, which is shorthand for Implementation of Evidence-Based Facility and Community Interventions to Reduce the Treatment Gap for Depression. As the name suggests, our program is designed to test the scaling up of psychosocial interventions for depression in low-resource settings. In this case, Goa, a small state on the west coast of India. As we all know, depression is the leading cause of disability worldwide and accounts for about 40% of disability adjusted life years or DALYs attributed to mental and substance use disorders. In India, despite 3 decades of implementation of the government's flagship district mental health program, only a third of the states has more than 50% of the population covered by the initiative, and the treatment gap for depression remains high at 85%. Broadly, two kinds of barriers perpetuate this large treatment gap. The first kind are supply side barriers to the delivery of evidence based interventions, notably, the lack of skilled human resources. Task sharing to non specialist health workers, one of the grand challenges in global mental health, has become one of the most widely implemented innovations to address this barrier. The evidence on the acceptability and effectiveness of task sharing of psychological treatments for depression in LAMIX is robust. This evidence base testifies to the high levels of acceptability and effectiveness of brief psychological treatments delivered by non specialist health workers in routine care and community platforms. The Healthy Activity Program is one such psychological treatment developed by us, which is being scaled up through our IMPRESS program. The second kind of barriers are demand side barriers, notably the lack of appreciation of the distress associated with depression as being a health problem, which combined with the stigma attached to mental health problems leads to low levels of demand for depression care and low levels of adherence with care. There is much less evidence on interventions which seek to increase demand for care through community based interventions to address mental health literacy and improve adherence in LAMIX. Our Vishram program is one of a handful of evidence based examples of such an intervention and is the basis for the second evidence based intervention being implemented through our IMPRESS program. Thus, access to depression care in LAMIX remains limited due to both demand and supply side barriers, such as low recognition rates of depression, stigma associated with mental disorders, and the lack of access to contextualized and affordable evidence based psychological treatments. This results in both the low contact coverage as well as low effective coverage for depression. Through IMPRESS, we aim to integrate the Healthy Activity Program and the Vishram Community Program to increase both the contact coverage and effective coverage of an evidence based psychological treatment for depression, and in doing so, reduce the treatment gap for depression in a cost effective manner. We will do this by implementing and comparing two task sharing models for delivering the Healthy Activity Program. One as a standalone intervention, which we will call the facility only model, versus being integrated with an evidence based community intervention, which we are going to call as the community model, delivered by existing health facility and community based agents aimed at increasing demand for care and improving treatment adherence and effectiveness. The health centers randomized to the facility only model will receive the Healthy Activity Program, a manualized psychological treatment based on behavioral activation, which will be delivered by existing healthcare staff who will be trained through a digital platform. On the other hand, the health centers randomized to the community platform will receive the Healthy Activity Program, but in addition, the catchment area communities serviced by these facilities will also receive a range of community intervention strategies such as mental health awareness activities, active identification of potential patients with depression in the community through key informants, facilitating their access to care by providing psychological first aid, and advising to visit the facility for screening and coordinating continuing care of patients receiving counseling through home visits to encourage activation, homework completion, and follow up with the counselor, and engagement with family members to support the patient. We will conduct our research activities through two phases. In the first phase, we will adapt and test the strategies of the facility and community interventions in the study context, as well as test the procedures for the trial to ensure their feasibility and acceptability prior to the main trial. In the second phase, we will conduct a hybrid implementation trial to compare the impacts of the facility only model and the community model on a range of outcomes. After several delays in initiating the program due to administrative reasons and COVID 19 related issues, we have now started the first phase of the program. We have strong commitment from the local, state government, and health department to scale up the program across the whole state of Goa. To the best of our knowledge, this will be the first systematic attempt in any low and middle income country to scale up an empirically supported psychological treatment in primary care, integrating this implementation with an evidence based community intervention to promote its contact and effective coverage. In doing so, Impress will address one of the major unanswered challenges in global mental health, and that is the methods, acceptability, effectiveness, and cost effectiveness of integrated community and primary care based approaches to reduce the treatment gap for depression.